of acute are focused on preoperative visualization of the vermiform appendix. Without imaging, the negative appendectomy rate can range between 19 and 21%. As is well known, the main diagnostic options for acute appendicitis include X-ray computed tomography, magnetic resonance imaging, and ultrasound of the appendix. The choice of particular method depends on the hospital's established approach. In the United States, CT imaging of the appendix is the most commonly used technique. In other countries, the emphasis is placed on ultrasound diagnostics because it's a more cost-effective method that does not expose the patient to radiation. In our country, majority of patients with suspected acute appendicitis don't undergo CT or MRI, making ultrasound the only available option. However, ultrasound has not significant limitations. Its effectiveness varies greatly between hospitals and depends on the experience of the physician as well as the patient population, whether the ultrasound is performed on children or adults. One of the biggest drawbacks of ultrasound is the inability to locate the appendix during the examination. According to the literature, the ultrasound visualization rate of the appendix ranges from 23 to 61%. In our healthcare system, surgeons don't perform ultrasound examination themselves. This task is carried out by ultrasound diagnostic specialists. In practice, the low accuracy of ultrasound often leads to situations where surgeons encounter erroneous ultrasound reports or cases where the appendix is not visualized. As a result, many surgeons lose trust in this method. I have dedicated my work to find the answers to why ultrasound imaging of the appendix is so high operation dependent and how this diagnostic method can be made more objective. The three main issues in ultrasound diagnostics of acute appendicitis that would like to emphasize are low visualization rate of the vermiform appendix, especially when it is not inflamed, misidentification of the appendix leading to diagnostic errors, incorrect conclusions due to incomplete visualization of the appendix. The low visualization rate of the vermiform appendix can be attributed to several factors. Let's start with the equipment. Older ultrasound machines, especially those 10–15 years old, are not suitable for appendix visualization. They have insufficient resolution, making it difficult to detect the appendix, especially when it's normal or minimally inflamed. The next important factor is the workload of physician performing the ultrasound. Acute appendicitis is an emergency condition, and in many cases, the ultrasound examination is performed by a doctor responsible for evaluation all emergency patients admitted to the hospital. With such high patient volume, the physician may not conduct a thorough search for the appendix, as it requires additional time and effort, adding to an already heavy workload. Another factor is a technique used to locate the vermiform appendix during ultrasound examination. The least effective approach is when they place the probe in the right iliac region and move it around hoping to accidentally spot the appendix. Many doctors sought for the appendix at the point of maximum tenderness in the right iliac region, and if it's inflamed, this approach is usually successful. However, our main goal is to rule out appendicitis, which means we need to find a normal appendix. A more consistent and effective approach is when the physician first locates the cecum and ileum and when searches for the vermiform appendix in this area. Widely used technique is great compression of the anterior abdominal wall, where the examination is performed will simultaneously apply pressure with the probe on the target area. This helps to reduce the distance to the appendix or displace intestinal loop that may be obscured it. Great compression is very important and we always use it. Three-step methods for location the appendix is also well known. It involves examining the patient will lie on their back, then on their left side, and then back on their back again. I begin the examination using a linear probe within 10-12 MHz, as it's difficult to visualize a normal appendix with convex probe. Considering that the penetration depth of the linear probe is about 5 centimeters, every centimeter of distance between the probe and the appendix is crucial. We need to clearly visualize the appendix along the entire length from the base to the blind end. The appendix don't always appear as clearly as shown on this slide. It may be obscured by the intestines folded or positioned on the bottom of the ultrasound window. The position of the appendix is primarily determined by the location of the cecum. The following variations in the position of the cecum can be distinguished. The cecum located in the right iliac region, in the pelvic and high position above the anterior superior iliac spine. Therefore, the first step in the searching of the appendix is determining the position of the cecum. We look for the iliac vessels to understand the relative position of the cecum. Next, locate the cecum, which is most often found lateral and superior to the vessels. If there are loops of the small intestine in the right iliac fossa, consider the possibility of the high position of the cecum and move the probe upward towards the costal margin. If the large intestine does not end in the right iliac region, but continues medial to the iliac vessels, this means the cecum is located in the pelvis. Only the cecum is found. The next step is to locate the appendix, which originates from the cecum. When the cecum is located in the right iliac fossa or high in the lateral region, the appendix can be observed in the following positions. The positions of the appendix on the muscle. This means that the appendix is located on the psoas muscle just beneath the anterior abdominal wall. Since this is the most superficial position of the appendix, it's the easiest to locate and examine along its entire length. The next position is muscle pelvis. This positioning occurs only when the cecum is located in the iliac region and cannot be present if the cecum is positioned higher. In this case, the proximal part of the vermiform appendix is located on the muscle, while the distal part is positioned medial to the iliac vessels within the small pelvis. This position is characterized by the fact that the distal parts of the appendix is often not visible. As a result, we cannot be fully examine the appendix, which may lead to a misdiagnosis. Moreover, the appendix site located above the iliac artery is compressed by the probe, while the distal parts of the appendix located medially to the artery expands. It can be assumed that the distal part of the appendix is inflamed. If the vermiform appendix is positioned in the muscle small pelvic location, attempt should be made to extract its distal part from the pelvis. To do this, the pelvis should be elevated, for example, by placing a roll under the patent buttocks. Then the probe should be positioned on the cecum and gently press it so that it slides upward. In 20% of patients, this position results in cephalate displacement of the cecum, which allows the appendix to exit the pelvis. As a result, the appendix became fully positioned on the muscle and can be completely examined. In some cases, this technique also helps to extract the cecum from the small pelvis when it has pelvic position. The next variance in the paracecal position of the appendix. In this case, the vermiform appendix is poorly visible because it's folded near the cecum and is often particularly covered by it. When the vermiform appendix is positioned paracecally, it's often difficult to confirm that it has been fully examined. To improve visibility of an attempt should be made to shift the appendix onto the muscle. This can be achieved by turning the patient onto the left side, allowing the cecum to move onto the muscles. When the patient should be slowly turned back so that the cecum shifts into the iliac fossa while the appendix remains on the muscle. Also, this maneuver may seem complex. It's highly useful. When the appendix shifts into the muscle, the strengthens and becomes much more accessible for examination. If the appendix is not found in those three common positions, it may be located laterally or medially to the cecum. If the appendix is positioned laterally, it can be visualized by turning the patient onto the left side. This movement shifts the cecum laterally, allowing the appendix to become accessible for the ultrasound beam. Next, let's consider the medial position of the vermiform appendix, in which it's located beneath or above the ilium, under its mesentery or beneath the medial edge of the ascending colon. If the appendix is positioned anterior to the ilium, its visualization is not problematic. However, when the appendix is beneath the ilium and especially under the medial edge of the cecum and ascending colon, it can be very difficult to locate as it's obscured by intestines, particularly in case bloating. The improved visualization, the patient should be positioned as an angle the examined table. The angle should be adjusted so that when apply pressure with the probe on the abdominal wall, the ilium shifts medially and the colon moves laterally. It's preferable to position the probe in such a way that the ultrasound beam passes laterally to the recto-abdominal muscles, as these muscles can be impair visibility. When the appendix has to be scanned through the small or large intestines, Significant pressure on the iliocecal region may be sometimes be necessary, which can cause pain for the patient. The pelvic position of the cecum is a weak point in ultrasound diagnostics of acute appendicitis. In this position, the cecum cannot be compressed, and shifting it from the pelvis to the iliac fossa is rarely successful. As a result, the vermiform appendix may remain invisible when in case of gangrenous appendicitis. When the cecum is in the pelvic position, the appendix cannot be visualized in 2 out of 3 cases. In this position of the cecum, the first step is to identify the boundary between the large and small intestines and scan along this border following the medial edge of the cecum. If the vermiform appendix is visible in this area, it refers to the medial position of the appendix. The next area to examine carefully is around the iliac vessels, above them and medial to them. I refer to this positioning of the appendix as paravasal. It closely resembles the muscle small pelvic position when the cecum is located in the iliac fossa. The key difference is that in this case, the ascending colon is located above the penis, while the cecum is medial to it. In this position, the appendix base is usually not visible as it's deeply located within the pelvis. The appendix can also be visualized beneath the cecum at the pelvic floor, but only if it is inflamed. This is known as the subcecal position of appendix. However, it cannot be detected using a linear probe. A convex probe is required. If you have fully visualized that the appendix and it appears normal, acute appendicitis can be ruled out. However, if you are unable to examine the entire appendix, especially the distal parts, you cannot exclude appendicitis, as the inflammatory process may sometimes affect only distal parts of the organ. Therefore, if you have not seen the blind end of the appendix, this should be noted in the ultrasound report. So, the physician making the surgical decision does not rely solely on this report, but also takes the patient's symptoms into account. The described methods for location of the vermiform appendix allows its visualization in 80% of adult patient. If you have no other options for visualizing the appendix, applying this algorithm will reduce the number of diagnostic laparoscopies and appendectomies by at least 14%. Thank you for the attention. Goodbye.